addition to shock is a life-threatening condition caused by circulatory failure. Shock results in tissue hypoxia, cellular death, organ dysfunction. When tissues do not receive enough oxygen, the body begins to fail. Without rapid intervention, shock can progress to multiple organ failure and death. Categories of shock. There are 4 major categories of shock: distributive shock, hypovolemic shock, cardiogenic shock, obstructive shock. Each type affects circulation differently, but all lead to poor tissue perfusion. Distributive shock. Distributive shock occurs due to decreased systemic vascular resistance and poor perfusion. Blood vessels dilate, causing blood pressure to fall. There are 4 major types: septic shock, anaphylactic shock, neurogenic shock, toxic shock. Septic shock. Septic shock occurs from overwhelming infection. Inflammatory cytokines damage blood vessels and trigger clotting mechanisms. This leads to vasodilation, capillary leak, hypotension, tissue hypoxia, common findings, fever, tachycardia, hypotension, elevated lactate, NCLEX-CLU, warm flush skin early in septic shock, anaphylactic shock. Anaphylactic shock occurs from severe allergic reaction. Examples: medications, foods, bee stings. IgE-mediated reactions cause massive vasodilation, increased vascular permeability, airway swelling. Symptoms include hypotension, wheezing, hives, respiratory distress. NCLEX-CLU, airway is the priority. Neurogenic shock. Neurogenic shock occurs after spinal cord injury above T6. Loss of sympathetic nervous system control causes vasodilation, hypotension, bradycardia. NCLEX-CLU, hypotension plus bradycardia after spinal cord injury suggests neurogenic shock. Toxic shock. Toxic shock results from Staphylococcus aureus infection. Massive cytokine release causes severe inflammatory response and circulatory collapse. Hypovolemic shock. Hypovolemic shock occurs when intravascular volume decreases by 25 to 30%. Causes include hemorrhage, dehydration, burns, GI, fluid loss. As volume decreases, cardiac output falls, leading to tissue hypoperfusion. Hemorrhagic shock. Hemorrhagic shock is caused by severe blood loss. Common causes: trauma, GI bleed, ruptured aneurysm, postpartum hemorrhage. The body cannot deliver enough oxygen to tissues. NCLEX-CLU. Tachycardia is often the earliest sign of hemorrhage. Cardiogenic shock. Cardiogenic shock occurs when the heart cannot pump effectively. This causes decreased cardiac output, systemic hypoperfusion, myocardial ischemia. Common causes: acute MI dysrhythmias, right ventricular failure, medication overdose. Obstructive shock. Obstructive shock occurs when blood flow is physically blocked. Common causes: pulmonary embolism, tension, pneumothorax, cardiac tamponade, aortic dissection, pericardial effusion. Blood cannot circulate effectively to major organs. Stages of shock. Shock progresses through 4 stages: initial, compensatory, progressive, refractory. Initial stage of shock cells switch from aerobic to anaerobic metabolism. Lactic acid levels increase. Symptoms may be subtle. Clients may feel anxious, feel unwell, appear pale. Compensatory stage. The body attempts to maintain perfusion. Compensatory mechanisms include increased heart rate vasoconstriction, catecholamine release, aldosterone release. Blood is shunted to vital organs. Blood pressure may still appear normal. Progressive stage shock worsens and organs begin failing. Manifestations include oliguria, altered LOC hypotension, cool clammy skin, weak pulses, electrolyte imbalance. NCLEX-CLU. Progressive shock means organ dysfunction is occurring. Refractory stage. This stage is irreversible. Manifestations include severe hypotension, anuria, coma, respiratory failure, multiple organ failure. Death is imminent. Etiology of shock. Common causes include sepsis, burns, pancreatitis, spinal cord injury, hemorrhage, GI bleed, pulmonary embolism, aortic dissection, cardiac arrhythmias, allergic reactions. Impact of shock on overall health. Shock affects every organ system. Without treatment, organs fail, tissue dies, mortality increases. Older adults are at especially high risk. Clinical presentation of shock: initial stage, anxiety, pale skin, subtle symptoms. Compensatory stage, tachycardia, tachypnea, delayed capillary refill, decreased pulses. Progressive stage, altered LOC, hypotension, oliguria, ashen skin. Refractory stage, coma, severe hypotension, respiratory failure, anuria. Septic shock case study: an 88-year-old client with UTI develops fever, tachycardia, hypotension, hypoxia, restlessness. This client is likely developing septic shock. Priority nursing actions: oxygen, IV fluids, blood cultures, IV antibiotics, rapid provider notification. Lab and diagnostic testing: CBC evaluates infection anemia and WBC count. Electrolytes: monitor sodium, potassium, and acid-base balance. BUN and creatinine evaluate kidney perfusion. PT and PTT assess clotting function. ALT and AST monitor liver function. Lactate, elevated lactate, indicates poor tissue perfusion. Blood, urine, and sputum cultures identify infection source. Cardiac enzymes assess myocardial injury. ABGs evaluate oxygenation and acid-base status. Diagnostic studies: ECG detects dysrhythmias and ischemia. Chest X-ray identifies pneumonia, pulmonary edema, or pneumothorax. CT scan evaluates internal bleeding emboli or organ injury. Role of the nurse: provide emotional support and education to clients and families, explain ICU environment procedures, diagnosis, prognosis. Frequent reassessment is critical. Nursing process: assessment, recognize subtle changes early. Monitor vital signs: urine output, LOC, respiratory status, hemodynamics, oxygenation. NCLEX, clue: restlessness may be an early sign of hypoxia. Nursing process analysis: analyze trends in blood pressure, oxygenation, urine output. Mental status: lactate levels. Identify deterioration early. Nursing process priorities: early recognition saves lives. Prioritize airway, oxygenation, perfusion, circulation. Nursing process planning: collaborate with ICU team, respiratory therapy providers, pharmacy. Ensure equipment and emergency supplies are ready. Nursing process implementation: interventions may include IV fluids, blood products, vasopressors, oxygen, mechanical ventilation, hemodynamic monitoring, urinary catheter, insertion, enteral or parenteral nutrition. Vasopressors in shock: norepinephrine is commonly used to increase mean arterial pressure. It causes vasoconstriction to improve perfusion. NCLEX clue: monitor for tissue ischemia and extravasation. Hemodynamic monitoring: arterial line, provides continuous blood pressure monitoring. Common site: radial artery. Central venous pressure monitoring, measures fluid status. Pulmonary artery catheter, measures cardiac pressures and cardiac output. Mechanical circulatory support: advanced therapies may include intra-aortic balloon pump, LVAD, ECMO, cardiac transplant. These therapies support circulation when the heart cannot maintain perfusion. ABG interpretation: ABGs, pH 7.32, PCO2 38, HCO3 20, PaO2 70. Interpretation: metabolic acidosis with hypoxemia, likely caused by tissue hypoxia, lactic acid buildup. Septic shock: expected treatments: oxygen, IV fluids, vasopressors, antibiotics, ventilatory support. Nursing process evaluation: continuously evaluate response to interventions, lab trends, hemodynamic stability, urine output. Oxygenation: outcomes may be improved, worsened, unchanged, high yield. NCLEX review: shock equals inadequate tissue perfusion. Early sign: tachycardia. Late sign: hypotension. Lactate: elevated with poor perfusion. Septic shock: warm skin early. Neurogenic shock: hypotension plus bradycardia. Anaphylactic shock: airway swelling and hypotension, cardiogenic shock, pump failure after MI, hypovolemic shock, fluid or blood loss, obstructive shock, physical blockage of circulation. End of lecture activity. Have students identify type of shock, stage of shock priority interventions, expected labs, compensatory mechanisms, emergency treatments. Example, client with fever, hypotension, tachycardia, elevated lactate and confusion. Correct answer, septic shock in progressive stage. Use side-by-side comparisons of distributive shock, hypovolemic shock, cardiogenic shock, obstructive shock,